Ladies and gentlemen, let's swiftly move on to our next lecture. May I invite the moderators for this session, Dr. Jnanamurthy Mayurudan, consultant cardiologist, Dr. Bharti Aranasinghe, consultant cardiologist, and Dr. Jagat Herath, consultant cardiologist, to take the stage. Thank you.
So it's I think we already got few minutes to get you connected. So we are going to talk about, Professor Jeans is going to talk about bifurcation stenting, which is an important topic for all of us. So over to you, Prof. Right.
So let me try a bit about the bifurcations. That's what you asked me to talk about. And we have a step-by-step provision where we will look at provisional T, tap, culotte, DK crush techniques, and then even some nice OCT examples. So this is the whole schedule we have in the European Bifurcation Club, the MAT classification, main across first, distal first, side branch first. And you'll see in the recommendations of the Bifurcation Club, it's usually provisional is on the first three positions. It's provisional as step 1 or option 2 and option 3 every time you consider it. If you are going to look at different techniques, you will have to find a good indication, and we'll discuss shortly some examples of that. Sizing of course for the bifurcations, as you all know it probably by now, is using according to the distal main vessel. That's where you have the correct diameter, and then you will optimize the POT, the proximal optimization technique, for the proximal sections just to the carina, proximal to the carina. Then restoration of flow with the balloon is frequently sufficient if you have an occlusion of the side branch, and that's still called a professional approach. The Will out T, where you pass on a stent later on, if you still have not good sufficient flow in the side branch, is the simplest way to solve any problem. And then, just as I said in the beginning of my presentation, upfront two-stent technique is rarely indicated. Then some more tips and tricks. Realize that wiring of the side branch prior to the main branch stenting is just usually a marker of where the side branch is. So we call it a safety wire, but it's not, can hardly be used as a wire to push over your balloon. But it is as a marker, but it also helps to reduce the bifurcation angle, which makes it more easier to recross if you have to recross with your new wire. It may improve side branch patency after main branch stenting just by being there, and it helps to keep some floor. And then in case of clinical urgencies, you can use another balloon on this jailed wire to open up the vessel and give you time to reduce the chest pain from the patient at the moment, and follow it up with a new wire and a new balloon to complete the bifurcation. And the point number 5 for the jailed wire, it has some part of an anchor. So if you have to push a new balloon over your recross wire, it helps to support the guiding catheter to not disengage while you're pushing your balloon. So it's just slightly in anchor. So we have an example of side branch access. There's a male patient, 60 years old, with unstable angina. Quite some years ago, and I wanted to show you this angle because this is absolutely here in the area. There's a significant stenosis. You want to treat across this significant side branch, but look at the unfavored angle of the side branch, which is more than 90, probably close to 120 degrees in the opposite direction. If I zoom in on the other side, even, you can see how more it looks like that it is over 90 degrees in the backwards orientation. For this kind of examples, you need a special curve to use the wire, get it into the side branch. But for today, I really wanted to show you how it stretches out the curve here. So you can realize if you have one wire in, it's much easier to get your second wire in. So it stretches the entry of the side branch. In this case, now there, after implantation of the stent, the vessel is still open. We have entered, inserted the second wire, and then we can easily bring in a balloon and do a kissing to complete the bifurcation. So this is a proximal optimization technique. I have some nice image to show with you. So what you realize if you're doing distal sizing, you will see that you have proximal malpose struts that is in this illustration. Now, if you do the pot, which is then the larger balloon, more proximal, it's a shorter NC balloon, 0.5, 1 millimeter larger to the main branch stand, and that will oppose the proximal segment. And that's what you will see after this one. So the pot is an important section of your provisional bifurcation technique. About side branch opening itself, you can see, according to the randomized data routine, kissing balloon inflation in professional bifurcation does not improve clinical outcome. So we do it as I showed you in this case, because I was afraid that after pulling the wires, the angle would become again very unfavorable, and I wanted to do a balloon at that moment. But it's not shown, demonstrated in randomized trials that we have to do the kissing balloon in the end. In case of side branch flow impairment, that's less than TMI3, or chest pain or ECG changes, then it is recommended to do kissing balloon inflation to restore the floor. If you do the provisional strategy, then we will try to push the side branch wire as distal as possible. It's recommended to usually 2 NC balloons. That's not always the steps I follow, depending on the branch of the NC balloons. There's an alternative to kissing balloon, pot side pot. I will show you that also could be considered. So this is the kissing balloon and the pot side pot. Here we have proximal optimization first, the recourse, side branch, and then again, if you inflate the side branch balloon, you might malpose, disengage the struts on the opposite direction, and that's why the pot is done in a second time. So this is what we call not anymore kissing balloons, but we can replace that in a pot side pot strategy. Any questions at this moment?
Anything from the audience? No, it's quite clear about the initial part.
Okay, thank you. Just to see that the communication is correctly, and we continue you with the summary of the professional strategy, where we have the pot, we have a kissing balloon inflations, and we have pot side pot as a rapid strategy for very frequently recommended.
Hello, yeah, Professor, where do you place in the pot? Where do you exactly space the distal stent balloon marker? That would be a quite important place point, I would say.
What is interesting is I think you have to, because this is drawn as a balloon with very long shoulders. That is probably what we don't have anymore at these timings. So it's depending a bit on the overhanging of your balloon and the shouldering of your balloon. But we just usually say the marker should be at the carina level. That's the only way to push out the struts which are in front of the side branch as much into the side branch. By that way, you increase the distance of the area of the cells in this entry area for the side branch. So in this case, the markers there, but you can see this one is much more shouldering than the balloons we have in practice, which have a very strong shouldering, but some more overhang in here. And the whole purpose is to have the largest area of your balloon pushing up the struts into the side branch while not shifting the carina anymore. That's why the marker is usually close to the carina. You don't want to shift the carina, you just want to shift the struts proximal to the carina.
That's a question from the audience. One.
Yeah, Professor Genus, just want to your comments on now when you jail the wire and you deploy the stent, do you recommend doing the pot, keeping the wire jailed, or you rewire and then do the jail?
Absolutely, absolutely. I think all of us, the only wires I usually don't jail are the FFR wires, because they have a complex construction with the sensor, which is a little more bulky area. But all the other wires at the moment you can easily redo. What I don't do in the first step, that's my personal part of it. I'm not always doing the pot with a very high pressure. The whole purpose of the initial pot is to get apposition. As was demonstrated, I can go back to the slide. The most risky section of your rewiring is that you will be behind some of these struts. If you are again with your new wire behind the struts, then the pot or the provisional is not going to be a provisional, but there will be some crushed sections in there. So you have to get apposition, but you don't have to dilate the lesion. You can do that in the second pot. So in this area, in A, the first step, it's principle low pressure, just to modify the carina and get full apposition. In the last pot, there's no gelled wire, and you can really go up high pressures. There's nothing gelled anymore.
Thank you.
There's another question. Sometimes to do the pot that we don't have the size of the lesion, length of the lesion is not adequate with the smaller size of balloon. So what is your option at that time? Do you take a look the size available and you pass the lesion, do the pot or?
No, absolutely. It's a very valuable comment. It's one of the sections you have to think on at the beginning. If possible, we will do the 6 or the 8, depending on the minimal lengths of our pot balloons we have available, which is 8 in our center. So if you do this provisional, you try to have 8 millimeters of stand proximal to the carina, and then you will have full coverage of that section.
Okay, thank you.
So this is a bit older case, but there are some nice examples in it. And that's why I wanted to show to you. 70-year-old male with an inferior posterior infarct, and he had some PCI of the circumflex, an FFR of the left main in 2007, but 10 years later came back with progressive angina and this bifurcation lesion in the left main. The questions is we can discuss shortly PCI or cabbage for this patient who's 70 years old for left main, 1 or 2 stents, left main diameter potentially larger than 5 millimeters, and a large tapering from left main to LAD, which is in my opinion close to 1.5 millimeters. We discussed the patient in the heart team using the syntax score, which was below 23 points. And then we agreed with the surgeons that this patient would be very good options for PCI using 2 wires, single stent crossover, as just discussed. Okay, we'll talk not so much about the self-expanding stent, but about fenestration of the struts to the side branch as is possible with this stent, which will really open up the cells. With the standard cells, you won't disconnect, but you can, in the carina area, expand the cells to that side branch area. So I'll show you shortly the steps, the pre-image, the kissing pre-dilatation, putting up the stent from LAD to left main. Here you can see that. Oh, this one is not linked correctly. That's too bad. And then we do the pot, and you can see the marker of the balloon really close to the side branch, and then the fenestration. This is recrossed, opened, and we have the end result. So if you do the recross, you can do that visually. What the tip and tricks are there is that you bring your wire into the LAD with a curve, and then on the way back with the tip of the wire in the direction of the circumflex. The moment it kind of jumps in, flips in, you're usually at the most distal cell, and you forward the wire into the circumflex. And if you have the option to do an OCT in between, you can see indeed in this case the wire is in the distal section of the bifurcation of the side branch, distal cell, not the proximal cell. How to use that area to recross and do the fenestration. And there's some nice disposal from the people we worked with in Rotterdam. You can see that if you have a regular stent and you have your wire in the distal cell, how you really open up the ostium of the side branch. So this is the case of 2016. You can see there's the OCT. You can see that the wires are pretty much proximal. And in the other section, you can, in the longitudinal reconstruction, you can see we have under expansion in the proximal, of in the distal main, just to the bifurcation area. This is not optimal yet, but we have full apposition in the proximal main branch. There's no disconnection, so we have to use a larger balloon, a new wire, to be sure that we have better opening of the side branch. We have again a pot, and first I dilated. You can see in this case the marker is just more distal in the main branch, because we had seen that there was still some under expanded area of the main branch, both on this stent boost image, both on the OCT I showed you in the previous slide. And with the pot, then we have the marker really close to the carina. Now we have a new result, which if we look at it, you can see now with this wire, which is more distal, crossing, opening the struts in front of the circumflex, to be sure that we have a better, and the under expansion, which was originally in this section, is now gone. And the 3D reconstruction, you can see this is a dedicated stent which has been taken off the market for non-commercial, for commercial arguments, that was able to disconnect between two struts. But you can see how you can push some struts into the side branch area to have it very open. These are old images. I think I can skip that for you. If you have distal OCT guided, then you have left malposition and larger areas into the side branch. So do you have more time, or do we have all the questions done like this?
I think we can proceed and we'll have the discussion at the end. Or for the time being, I think everybody okay? Any questions from the audience? We can carry on. Yes, Prof.
How much time anymore?
We have 40 minutes more, and we can have the question time in between as well as at the end. Yeah. We have 40 minutes more. 40 minutes. 40.
Oh, that's a long time. I can continue. I have to see what's in that, because I want to show you a demonstration of a two-stent approach. Main across first, and then to complete with a tap. That's usually, if you have to bail out, the most frequently used approaches. We can also discuss about DK crush, but that's less frequently done. So recommendations for the bifurcation flap T and T and tap stenting is recommended for bifurcations with right angles. If the angles are smaller, you can either do the culotte, which is here on the left side, or the DK crush to crush the side branch stent and rewire it and complete it that in two steps. That's the second case then. That's also a left main bifurcation, but that's a patient who is much older, had the primary PCI 1 year earlier for the anterior MI. There's quite some stents in the proximal LAD and the circumflex, moderately depressed ejection fraction, and now coming back with recurrent chest pain and this distal left main lesion. The right, some disease, but not very important, but also some lesion in the proximal circuit. You can see that in this orientation. There are some more issues outside the left main itself. So when the patient presented, we had an emergency angiography, and that we said, okay, with this right coronary artery, this age, we have to discuss shortly with the surgeon. So we had the heart team on site, with the conclusion that due to the age, the previous MI, etc., still a percutaneous option was preferred for this patient. The patient, we did do some OCT imaging, which was helped us to see all the problems in this case. So the left main shaft was 6 square millimeters, but the distal left main, you can see in here, that is 1.2 square millimeters. So this is a really tight lesion. You don't need an FR to conclude that. But it's also a complex lesion. Calcium in the left main, in this area, calcium in the MLA area. The proximal LAD was also, you can see some of the struts. So the struts of the previous stenting were very close up to the ostium of the LAD. But the area by itself was pretty okay yet, 4.8 square millimeters. We looked at the circumflex, as you can see in this projection, and by the OCT measurements, it's 1.3 square millimeters, so really tight circumflex ostium with calcium, shown pretty deep calcium, thick layers of calcium. And then somewhat deeper, there is the proximal circumflex stent implanted 1 year earlier, nicely covered, not so much intima hyperplasia. So the strategy was that we decided to do rapidly and shortly the proximal right coronary artery, and then worked on pre-dilatation of the circumflex. And you can see how much nicer it opened already. But the arrow is there that we might have some shift of the carina for the LAD. The stent, 3 millimeters wide, 12 millimeters long, was implanted crossover from left main to circumflex. We did do the OCT at that moment from the circumflex pullback. You can see how much the carina has shifted. The LAD is now banana shaped, compressed. Some struts of the LED still there, but this is not a situation that I will accept, especially if you do a pull back from the LAD. So now we did do the OCT from the other vessel, and you can see we can even measure the area there, 2.8 square millimeters. So that help made us the decision to change our strategy from crossover stenting only to crossover and do a balloon with 2 kissing balloons, 12 millimeter balloons, and the carina shift was pretty much resolved by that, and that was pretty much okay, and we were pretty happy about that. But we still had the OCT, and now looked at the OCT what was showing us to the LED, and we said, okay, looks quite somewhat better, 3.8 square millimeters. But also now we have inside the stent and the old stent, the intima was disrupted, and somewhat in the depth also we see a dissection extending beyond the stent edges, but also this flap inside the stent. In the old stent, we decided that this was not sufficiently resolved. You could argue with that because, as initially I said, if you do a crossover strategy and you have TMS3 flow, no chest pain, no ECG changes, then the professional strategy should be okay. But in this case, we're talking about the left main, a previous implanted stent in the LAD, and a demonstrated dissection. It might not be the hugest dissection on the OCT, but it's a proximal LAD was the main argument, and we didn't reach the area we want to have for a left main bifurcation treatment. So I said we have to convert now to a Culotte to do a second stent. the bifurcation area. You can see how wide it is. So this is if we pull back from the LED, the OCT. You can see it is really H-shaped. Both side branches, those branches are really open, um, and struts of both stands are opposed. So this is how the um, bifurcation looked. OCT guided re-intervention of a patient who had initially attempted just to avoid the left main strategy by putting some stents just distal to the bifurcation. Came back with the issue 1 year later and had initially a provisional strategy which was converted to a Culotte due to the suboptimal result of the provisional strategy.
Just excuse me, Dr. Van Jennens. Now, we don't have yet the OCT in our setup. Now, have you been doing all your cases with OCT or you use IVUS? And when do you think the IVUS is more superior to OCT or OCT is always superior to IVUS? What is your opinion on this?
I still use the IVUS quite sufficiently in left main. It's depending on the complexity. The OCT, it's if possible, it has the resolution. It has the details to see all these dissections, etc. The disadvantage of the OCT in left main sections is that you have to give the contrast to flush the blood out, otherwise the OCT won't see anything. That means that you have to have your guiding catheter nicely in the left main shaft. Now, if you want to stand out to the ostium of the left main, then your guide catheter has to be out in the aorta, and your flush won't clear the vessel enough to see the left main. Also, if you have a very tight left main, you might not be able to flush the contrast before dilatation, and you won't see an image. Or you have to engage the bifurcation the guiding catheter pretty deep up to the bifurcation to get a clear view. And you don't want to be having a lot of wedging of your guiding catheter to do the OCT. So these are some moments that I will avoid doing OCT, and I would still prefer our IVUS. The IVUS still can give the same results. The data, you know that you have to 8 square millimeters in the left main, 6 in the LAD as an end result, are IVUS based. So if you use IVUS guidance for optimization of your left main bifurcation, you know you have hard data to work on. So both have their arguments. The OCT, if possible, gives you the highest quality images, but IVUS is still workable.
Just one more question now. You used the gel balloon technique in any of these occasions, or you just put the gel wire?
Oh, I wanted to show you the gel balloon case I did earlier last week, but somehow I had in my agenda the presentation was tomorrow, so I cannot show you. That was one I was really afraid of losing the side branch with more than 90-degree bend. And that's the case where I used a gel balloon. It's not very frequently necessary. I don't know what's your opinion, but it's not really recommended by the Bifurcation Club. There are some people in the world doing that. I think it's a very exceptional case if you do that.
Yeah, you're correct, and we also don't frequently use this gel balloon technique. Only when there's a rare occasion where you think of losing a main, probably LAD, D1, and that sort of situations where D1 has to be rescued against the LAD.
Yeah, are there any other strong arguments there? Is everyone aware of the technique of the gel balloon there in your audience, or? Do you have to explain it to the audience more?
The jail balloon, of course, this is being recognized previously. It was reported from Singapore and Indian cases. And some of the operators, they use it to make sure that your flow is not occluded while you are opening the diagonal against the LED. And their vessels are both in like 2.5, 275, and with Medina 111 lesions, where you have to keep the diagonal patency. And then with the gel balloon, you can definitely wire the LED after opening the diagonal, so that you will not lose the LED at all.
Do you then routinely inflate the side branch balloon, or just in case of occlusion of the side branch?
Yes, only in occlusion situation you open up the gel balloon. Otherwise, you don't open up. You just leave it there. The smallest balloon you use.
You use the smallest balloon. You
Yeah.
rewire before you pull the balloon.
Yes.
Do you and how much resistance do you have on it when you pull the balloon? Can you explain that?
How much? No, there's no resistance at all, because you don't deploy the stent into the maximum.
So just like, yeah, and that's what was but when I did do it last week, it's very the balance, because you want to do the pot. The pot should be done not shifting the carina, so proximal to the carina, before rewiring. So at that moment, I had indeed what I said in the beginning: the pot with a low pressure, or
Yes.
to get square.
Yeah.
If the side branch is then still open, you can rewire and pull
your
the
balloon
jail
out.
balloon.
Yes.
And then you go up in a high pressure pot to oppose the proximal part, which is probably
Exactly.
now opposed in the area of the jail balloon. Okay, thank you for that explanation. In the meantime, I thought that it really required some more discussion. People hear about it, but you have to do it correctly and see the issue. There's the complex wiring. Good. We have the time for that one probably. This is the loop, and I'm lucky that is on this laptop. It's ready, so you can see the full loop you have on your wire. You push it beyond of your side branch, and you have the other tip like this. I can start it again. So you have to kind of have two curves. This is a small curve you have on the tip for the reverse wiring of the side branch. This is the section where you have the full loop. And maybe somebody also wants to comment on this one or not?
Yeah, I think this is commonly used in the situations like this, where the diagonal takes a curve, and in a more difficult angle, where you pull the wire out with a curve, as you have mentioned, and then the reverse wire goes into the side branch. But you need to have the support of the microcatheter with this.
Thank you. Exactly. So, and also the length of this curve, because indeed in this case it requires quite some work on this, because initially during pullback you see you only have a very short section in the side branch, and now you have the kinks here, the bends here. So if you start pushing again, it really doesn't want to support. So that's why the microcatheter would be of help to see if you can push it over. I redid the case, and the difference in the second time crossing was I used a much longer section here. So you would have more into the side branch before you have the kink, almost up to the part where you go from soft to more supportive section of your guide wire. But I managed to get it in. and even without a microcatheter. But these are, I would say, 2 trips if you have to do this to engage into this kind of situations.
One question, any type of wire, would you select coated wire? What type of wire would you use for this?
No, I think probably one of the high-tech double coiling wires you see now more and more. We used very frequently the Xeon wires, but it's just a technique which has been demonstrated for 10 years, even with the BMW, etc. No special wires needed. The curvatures in your new wires are more consistent and more durable, so that's what I prefer. You
I think,
can see
Prof, you
this
can
one.
go ahead. Yes. Yeah,
Yeah,
you
I
can
go
go ahead.
ahead with the longer one, and now with the longer tip, and you can see you have much more support. And then with gentle turning, it came in, and that's all you have seen. I have one more case for you, I think, and then I think I'm done for today. Now we talk about recovery of an occluded side branch, and this is about 54-year-old male patient who has a cardiomyopathy, EF 35, diagonal occlusion, no PCI. Later on, EF was deteriorating. The patient refused an ICD, but then afterwards he had an out-of-hospital cardiac arrest with successful resuscitation. But follow-up angiography after that one, there was a CT of the LED and an osteal disease, which demonstrated ischemia and viability in these 2 areas. So that was demonstrated. The CMR was not successful. Patient was 130 kilo, but the W mean, the cardiac output was increasing from 4.3 to 7.3, which was competent with viability in the anterior wall. Now I show you the images. Hope you can see it well enough. You can see how much all the diagonals are developed, and the LED is occluded. But we still had the ambition to open that one, which was using a guide liner, 1O balloon, and in this case a microcatheter turnpike gold. And then we had 2 wires in. This is difficult bifurcation, of course, because you already did see some disease, also potentially getting close to 5 millimeters in the diagonal branch. And the more you're working with balloons on the main vessel, the more risk damage to the side branch, I would say. So we decided for pre-dilatation of both branches. And you can see our jailed wire, which is now indeed lost flow, TME0 flow in the diagonal after stenting the main branch. Could have done something with a jailed balloon in that case. But we had the access, we had the safety wire in there to help them understand this where we had to go. Now, the OCT, you can see that is nice images again. In this case, you can see how this is the wire in the main vessel with some shadowing and some struts with shadowing, and the wire in the side branch. But in this case, with shadowing, but also tissues left and right, really demonstrating the occlusion of the side branch. If you do 3D reconstruction, the same occluded side branch, no lumen over there. Now I tried to rewire that following the first wire, which is in that direction. Looks like the fielder again. Unfortunately, you can see how much it goes into the dissected area of the side branch and not getting into the true lumen. Then I tried what also is one of the options, try to bring on a balloon on the safety wire. But you can see the guiding catheter is getting out, pushed out, and this safety wire is unfortunately indeed probably pushed so much in the diseased area that even our smallest balloon didn't pass in that direction. Then I tried the next step is to anchor the main branch with a balloon in the main branch, deep intubation during that anchoring, and then that's the only moment I was able to push in the balloon. And then I will go up for a 2 millimeter balloon and see if we can see the flow in there. I hope so. Pull back OCT, main wire, main branch wire, fully approached, well open distal LED, and here's the area where the strut is coming. But that's this now on our safety wire, and we realize that. So this wire, but you can see struts here, and we have malposition. We had inflated this balloon. The jailed wire is still behind the struts, but at least we have opened access to the side branch, and you can see if you have a reconstruction of that, you can see the algorithm also knows TT text red struts which are malopposed. We knew it was going to be malopposed, but also quite some deformed by using the safety balloon. Another reconstruction, red section, struts overhanging on our jailed wire. So we had now to do a new recross and see if a second new wire is in the correct area. And there's coming in the second wire. Show you again from here. A bit underneath some struts, but much better than the initial wire. So these are struts, wires which are underneath the struts, but this one is getting, this one is having on the cross-sectional imaging already much later, distal to the closer to the carina recrossing, and then we were happy to do a kissing, do a pot, and get the final result where we can see how this wire in the second wire we had entered opens the side branch very nicely. With the pot really optimizing the proximal segment, the distal segment wide open. So show you the image again. Oh, that's just a still frame. So now the distal left main has the CTO is open. The CTO at the point of the bifurcation. The side branch is just with the ballooning opening pretty well opened, and we didn't put a second stand in there. So in summary, this case I showed you for this presentation on bifurcations. It's 3D OCT used to optimize the side branch dilatation. And the variability we discussed earlier, just the distal cell crossings, larger cell crossings or proximal crossings. There's no, I show you some nice images, but we could also say that there's no hard arguments to use OCT or the 3D reconstructions of the OCT in the bifurcations. In some cases, it might be helpful to confirm that you're in the correct position. A significant impact of this case with the rescue balloon, which was necessary. Thank you very much. I think that's the end of my presentation for today.
Thank you, Professor. There are some questions from the audience. One question is, does TAP technique has good long-term outcome?
That's a very good question. It's because if you look at the data, the experts and opinion is yes, we have very good results. The French people have very good results with it. But to quote you on the literature and say this is the follow-up, statistically over so many patients, you usually get a general follow-up of the provisional technique, but not so much on the TAP, which is also second question, if the TAP is really always protruding or that people are ending with a T, not so much protrusion of the side branch stand. So I cannot give you hard numbers, but the experience in European bifurcation clubs is very positive on the TAP.
There's another question. That when you, like your first case, when you stent the left main into circ and the LED is pinched, then what is the technique? You use Culotte or reverse crush? What is the better technique?
I try to avoid the crush. As the DK crush, of course, you have seen the results of the DK crush 5, but crush is for me as frequently as a kind of predefined strategy. I want to have my crush stand covered with a new stand. I don't use so much reverse crush, saying that you crush it in the end. So in that kind of situations, I prefer to create a culotte and get a position and avoid a lot of metal on one side, which is inside my other stand. If or if possible, if the angles are favored, also you can do really easy a tap on that situation.
Okay, thank you. There's another question.
Dr. Chinas, I have a patient, 48 years old female, stable angina, exercise CCG positive in stage 2 inferolateral, and angiogram shows large circumflex 4 millimeters, 3.5 to 4 millimeter size. Proximal circumflex has a bit of haziness, and LAD is half the size of circumflex, has moderate disease in the ostium to proximal, maybe 1 to 2 centimeters. What is your strategy of stenting this patient? Patient doesn't want to go bypass surgery. She's only 48 years.
Yeah, I don't even consider bypass surgery for the left main just by itself as an important issue. You do the bypass surgery because you have to put in 60 millimeter stent in one vessel, 60 millimeter stent in another vessel, and still you see remaining disease. Probably there is something where a new vessel is much better than for us. The left main, which is either provisional or even 2 stents, usually will give for the left main section a very good result, durable result as well. And even worse, if you're 48 years old and you will go get surgery, your progression in your left main disease will be terrible because of competitive flow, of distortion of your flow. And 10 years later, you might end up with one venous graft occluded and you have to do a CTO of a left main, which is not a very nice thing. So surgeons, yes, I respect them and we need them for diffuse disease and long sections, not for the left main, in my opinion. So you mentioned 3 things which I did capture from your case: a lot of tapering and somewhat osteal disease, dominant third. That's also an important one. 1 or 2 millimeters of disease. The experience there is that it's not relevant. It's 5 millimeters, which people keep as cutoff value. Also, what you could do is do a post FFR section. So if you think you see some tapering, you have themis reflow, normal, no chest pain, etc. You can change your provisional strategy to 2-stent strategy, a tap like that, if you still have a positive FFR in completing your left main procedure. So that would be provisional for the side branch, 2 millimeters. If in doubt, control with an FFR, and then go up for the second stent in that situation. The tapering, you have to really look at your tables. And there are 2 publications I think the last one was International Journal of Cardiology on overexpansion of your stent. Usually a 3.0 stent can go up to 4 or 5 millimeters, 5 millimeters for all stents. Sure for the 3.5 stents, but you have to see some manufacturers have 2 sizes of stents, other has 3 sizes of stents. And sometimes the difference is just there between the 3.0 or 3.5, which is either large or medium-sized stent. And the medium-sized stents all stents are just mounted on different kinds of balloons. We don't get 7 different diameters of stents. We have either 2 or 3 different diameters of stents, and that limits your maximum overexpansion. the 1.5 or 2 millimeters overexpansion is usually possible. So that would advice would be size distally and over dilate the proximal main with the POT. But be sure that you choose your stent with a size to the distal main, but has the proximal overexpansion capabilities to fit in your proximal left main.
Yes, Prof. Jenny, there's a good question came out of the audience actually now. Which antiplatelet agents do you prefer following bifurcation stenting in stable angina? Which is a good question. So what is your antiplatelet strategy after doing bifurcation stenting for stable angina? Is it aspirin and clopidogrel or aspirin with ticagrelor? So then for what duration?
Absolutely good question, and we have been really deep in this discussion in our regions with our collaborative hospital referring cardiologists. So the standard for stable angina is currently 6 months. Aspirin, clopidogrel. That's European Society of Guidelines. There's only one exception, or there's multiple exceptions for complex PCI. And there people use quite some different definitions, and we have that makes it a bit practical in our situation. So very long stents came out of the Paris registry on stent thrombosis. More than 60 millimeters of stents would give you the idea to prolong or go back to the old standard of 12 months at DAPT. CTOs and 2 stent bifurcations. Only crossover won't change our strategy. If you have implanted 2 stents, so that's either TAP, crush, or culotte, we think that with that kind of double layers, complex, sometimes 3 times of layer stents, it's logical to go back to the 12 months. We keep our clopidogrel because there is something on resistance, although it is a low number of patients.
Thank you. Any more questions?
There's another question from the audience. Do you routinely do kissing when you stent LMCA to LAD? When I think he's assuming the LCX flow is perfect, I think so. That is.
Also, a very good question. I'm thinking of the correct answer. The correct answer is it's depending on the size of your circumflex, how dominant it is. So it's a minor circumflex. I regard it as a diagonal branch, and I don't go for routine fenestration, kissing balloons, and pot again. It's just a crossover and the pot. If we are talking about the dominant circumflex, the last case I remember on that one is that even there was an occluded right coronary artery involved in it, then I still routinely open up the side branch of the left main, so the circumflex for these cases. It's depending on the size of the circumflex.
And what is the combination of antiplatelets you prefer? Is it aspirin and clopidogrel, or aspirin versus ticagrelor, or aspirin versus any other thing, or what do you think? The best dual antiplatelet strategy in bifurcation.
Yeah, it's not dedicated on bifurcation. We keep a bit close to the guidelines and the studies performed. So stable angina is clopidogrel, and ACS patients is Pasodera or ticagrelor. We still prefer ticagrelor in our hospital. So there's no routine to make the clopidogrel, Pasodera or ticagrelor the more potent current depth strategies for any bifurcation.
Thank you, Prof. And we had a nice time, and of course, very elaborative lecture. So we'll move to the next session with the interest of time. Thank you very much.
Have a good day then.